Here is one of the most important shifts in rational emotive behavior therapy. Events do not directly create emotional breakdowns. Beliefs do. The activating event matters, but the belief is the engine. If we want durable change in emotion and behavior, we must target the belief. In advanced clinical practice, cognitive restructuring is a strategic intervention. We identify dysfunctional cognitions that drive emotional and behavioral distress, and we replace them with more functional alternatives. In REBT, we are very clear about causality. An external event may provide the context, but the internal belief is to a large degree the necessary ingredient for the dysfunctional consequence. Treating symptoms alone is like mopping the floor while the faucet is still running. In REBT, we turn off the faucet. We go to the source, the belief. There is a simple 4-stage workflow you can use in clinical practice. First, identify the dysfunction. What emotions or behaviors tend to impair the client from attaining desired life goals? Second, conduct goal impediment analysis. How exactly is this emotional state blocking the client from attaining important desired life goals grounded in their values? How is it interfering with relationships, performance, meaning, or health? Third, engage in systematic disputation. Methodically challenge the irrational or unhelpful belief that is generating the dysfunctional consequence. Fourth, cognitive replacement. Install a functional preferential belief that can guide future responses in a healthier direction. The ABC model is your essential assessment map. A stands for activating event, the adversity, the trigger for the clients, or the situation. B stands for belief and inference. The belief is an evaluative thought the client assigns to the event, and the inference is the thought that assigns meaning to the situation or event. C stands for consequence, the emotional, behavioral, and physiological reactions that follow. Clients typically enter therapy focused on A or C. They talk about what happened or their emotions. Our task is to locate B. A useful clinical rule is this: if the client starts with A, ask about C. If the client starts with C, ask about A. From a practical standpoint, beginning with C, the emotion, is often efficient. Clients usually know their distress. Once you clearly identify the specific dysfunctional emotion, you can work backward to uncover the belief that generated it. One important clinical caution: do not get lost in the entire story of the activating event. Keep the model lean. Focus on the critical activating event, the specific moment that connects directly to the emotional consequence, not the whole history, not every detail, just the slice that triggered the reaction. In REBT, we do not classify emotions based on intensity. We classify them based on functionality. A functional emotion may feel painful, but it does not derail the client's ability to pursue goals. A dysfunctional emotion tends to paralyze, avoid, attack, or withdraw. For example, depression and sadness are not the same thing. Depression typically leads to withdrawal and hopelessness. Sadness allows processing of loss while maintaining engagement with life. Anxiety differs from concern. Rage differs from annoyance or righteous indignation. Guilt differs from remorse. Shame differs from disappointment. The goal of restructuring is not simply to reduce emotional intensity. The goal is emotional replacement, shifting from dysfunctional emotions to their functional alternatives. Once you identify A and C, your next task is to classify B. In REBT, dysfunctional consequences are usually generated by 4 major categories of irrational or unhelpful beliefs. First, demandingness, the musts. These are rigid, absolutist requirements. I must not fail. They must treat me fairly. Life must go my way. These demands create dysfunctionality. Second, awfulizing or catastrophizing. This is evaluating an event as 100% bad, unbearable, or catastrophic. A negative setback becomes a total disaster. This appraisal amplifies distress and can lead to severe dysfunctionality. Third, frustration intolerance, the I can't stand it belief. I can't tolerate rejection. I can't stand discomfort. This belief drives avoidance and procrastination because discomfort is treated as unendurable rather than unpleasant. Fourth, global negative ratings. This is when someone assigns a totalizing label to themselves, others, life, or the world. If I fail, I'm a loser. If she makes a mistake, she's stupid. Life is unfair. The world is horrible. These global ratings destroy self-worth, strain relationships, and foster hopelessness. Disputation is the active ingredient of cognitive restructuring. It is not arguing with the client. It is challenging irrationality with precision and persistence. There are 4 primary forms of disputation. Pragmatic disputation questions the usefulness of the belief. How is it helping you to believe that you absolutely must not fail? Empirical disputation questions the evidence. Where is the proof that you must not fail? Where is that written? Friendship or perspective-shifting disputation invites the client to step outside themselves. What would you say to a friend who called herself a loser for failing an exam? Logical disputation examines reasoning. How does it logically follow that because you strongly prefer not to fail, you therefore must not fail? These challenges can be delivered in different styles: Socratic questioning, direct teaching, humor when rapport is strong, or metaphor when resistance is high. Early in therapy, it is often useful to use multiple forms of disputation to discover which approach most effectively shifts the client's perspective. Disputation alone is not enough. Replacement is essential. We replace demandingness with flexible preferences. Instead of, I must succeed, the client learns to say, I strongly prefer to succeed, but I do not have to. We replace awfulizing with realistic negative evaluation. This is very bad, but it is not the end of the world. We replace frustration and tolerance with endurance. I do not like this, but I can stand it and move forward. And we replace global negative ratings with unconditional acceptance. Unconditional acceptance is the cornerstone of psychological health in REBT. It does not mean liking, approving, or excusing harmful behavior. It means refusing to reduce a complex human being, including oneself, to a totalizing negative label. Unconditional self-acceptance sounds like this: I made a mistake. That does not make me a worthless person. It allows accountability without self-damnation. There is also an important clinical nuance. In the wake of genuine tragedy, challenging a client's awfulizing too quickly can feel invalidating. Often it is more effective to address frustration and tolerance first. Help the client believe, I can survive this. Once they experience themselves as capable of enduring the pain, they are better positioned to reevaluate the event without catastrophic appraisal. Finally, remember that dysfunctional emotions tend to push people toward predictable behavioral patterns. Anxiety pushes avoidance, depression pushes withdrawal, guilt pushes self-attack, rage pushes to attack others. Effective treatment challenges the underlying belief while simultaneously encouraging behavioral change, approaching rather than avoiding, engaging rather than withdrawing, taking responsibility without self-condemnation. Through the systematic use of the ABC model, the classification and disputation of irrational beliefs, and the cultivation of unconditional acceptance, REBT provides a practical and powerful framework for helping clients shift from irrational distress to functional emotion, effective behavior, and purposeful living. Thanks for watching this video. I hope you found it helpful at some level. Have a great day.